So coming to now module number 3 of the clinical communication skills. What are the structures one can depend upon? This is one of the things, the famous Calgary-Cambridge guide. You can use it in your outpatient department or general practice model as well. What do? You initiate a session. How do you do that? You prepare your furniture and all that stuff so that it's adequately, appropriately placed, and you are comfortable, the patient is comfortable, and all the things can be done, and there is a personal space available, and you are not confronting eye to eye with the patient. There is space, he can see something else also, not only you. So that we will show you in the workshop further. Of course, you establish an initial rapport. You call the patient, you go outside, announce the name, and bring the patient along with you, open the door for him, tell him, request them to sit down, and that's what happens. Like a 5-star hotel does or airline people do. That's what establishing a rapport is. And most of the private hospital doctors, we all do that, and in the UK we do it in the government hospital as well. Right, then you identify the reasons why the consultation is in place, patient's reasons, and maybe your reasons if it's a follow-up patient as well. Then you gather the information by exploring patient's problems to further find out what's the disease part, which we all have been taught in the medical school, as I understand. But the important part is the illness part, which is the patient's perspective. And I'm parking the disease and illness right now for the next slide. I'll come back to it later. Of course, you try to find out the background information, the previous experiences, or what he has seen, what he thinks, and if he has had something like that before. You all are good at physical examination and have been doing it and have been trained in it well. That's not what we are here to discuss. Then you explain and plan by providing correct amount and type of information, which is the reason Mr. Arora has actually shared what he feels, and that is where, and I feel is absolutely correct, because I am related to him and I know the patient very well as well, and I can see what could have happened. The patient example which Mr. Arora gave, he was not given the correct amount and type of information, and that's what went wrong. But ultimately the doctor was not trained in it. But shall we keep on not getting trained? That's something we need to ask ourselves, because we'll be losing our family, our countrymen, our people this way, one place or another. Right. Of course, after that we judge, is the recall adequate and accurate, and has the patient understood better? How can you do that? One thing I by echoing. But I generally ask my patients, okay sir, what will you tell your wife when you reach home? What we have discussed. And then the patient will share with me. And at that point I'll come to know whether he's good recall, is he understanding correctly, and if there are any errors, I will correct him at that point of time. So that's how you can do that by this manner as well. And of course you can evolve some better ways out as well. Then of course achieve a shared understanding where you both agree that this is the best way of going further, and which incorporates the patient's illness framework. And we'll discuss illness in the next slide as I part it. And then a final plan and a shared decision making for the future. Of course, through and through, summary, signposting, sequencing, and timing go hand in hand, along with the non-verbal behavior, the rapport development, and engaging and involving the patient. Make them talk. Should not be a monologue, dialogue. And more the patient speaks, the better actually. Coming to illness versus disease. What do you think is a disease? Can somebody speak out, please? I want to know what you think about it. Anybody, please.
Not at ease.
Not at ease. Very good one. I like that. It rhymes as well. My son will love it. I'm telling you tonight. Anything else? Anybody? Okay, disease is something what we are taught in the medical school. It's TB, it's malaria, all that kind of stuff, you know. Isn't it? What's illness? Suffering. Suffering from what? That's absolutely correct. I'm just digging it further now. Suffering from what?
The situation of discomfort.
Absolutely correct. The situation of discomfort. By what? By the disease. That's the root cause. So what adds on it further when a disease happens? Is the suffering just because of disease or other issues as well?
Physical and mental.
Physical and mental, absolutely. So from physical, we have reached mental as well. So there is a physical and mental discomfort because of the disease. But what are other factors which were not bothering or were not a problem, become a problem automatically? What are those issues?
Social factors.
Absolutely. Like what?
Like he can't do the works he wants to do, he can't meet people, he can't go to the, he can't fulfill his ambitions.
He can't fulfill his ambitions if it's a long-term illness, and if it's a short-term illness, he can't go where he wants to. You can't come to work. And it's a daily wager. How will he eat his bread for the night? He earns and he eats for the night, he gets some money, and then he feeds his family. So it depends where you stand in the societal norms, and it becomes life becomes hell, depending on the levels. So that's what is the illness, the patient's worries and concerns and issues about it. So do you think illness is important? Very important. But are we treating it? That's the question. So disease is biomedical, but illness is patient's perspective. And the eyes is the demonic. It is, it's like the difficult venous axis, which gives you the trouble. Talking about illness is something like that. And once you start doing it, you will become good, and the way, if you are good at finding difficult venous axis, you will become good at finding the illness issue as well. But if you are not doing it, it's like the difficult venous axis. So, what is that? The ideas of the patient, the belief, what is he suffering from, what he thinks is right, what is happening to him, what's the worst thing he is thinking, which will come further when we have the workshop, hands-on. And what he thinks is the best plan. Of course, what you think you will share with him and then evolve it better. But sometimes they have better plan than we have as well. Until unless we discuss with them. There can be issue of something happening in the childhood, previous experiences, and what has happened with his relatives or kind of things. What are his thoughts, what are the feelings going on, and what's happening to him. And a non-medical person is nodding maximum I can see in the crowd, because they are the people who understand it better. We as doctors forget. And that is what we were before we became doctors. We understood it better, but that's what we forget now. But we have to realize that's important, and it has a general daily life. So, what are the tips to handle difficult situations and difficult scenarios? I will discuss in the next module. And at this point, if there are any questions, I would like to take it at this point. Thank you. You want to ask?
That will come in this module.
Okay. That's fine. We'll cover this module when it comes. Anybody else wants to ask anything at this point? Please. Any comments also? Are you liking what I'm talking about? Is it making any sense, please? That will encourage me to be more enthusiastic.
Yes. Different.
Thank you. Thank you. Sure. Yeah, please.
Most of the times as doctors when we are explaining a particular problem to the patient and we are giving different solutions. It can be medical solution, it can be surgical solution. Being a surgeon, I am giving sometimes surgical solutions. While giving surgical solutions, I also give them the possibility, what the outcome, and sometimes the outcome may not be great, but we are trying to best. And as we are telling a patient, they are nodding their head and understanding everything. Most of the time, patient is optimistic, so is the doctor optimistic. You want to give the best outcome to your patient, the patient wants to have the best outcome for himself. But sometimes, what outcome you want and what outcome the patient wants doesn't happen. While in your consultation, you've actually explained to the patient, but because the patient is only hearing the good side of the story, the bad side of the story you've explained in the talk, but he's not really analyzed it or internalized it. When the bad thing actually happens, the first thing starts as a blame game, that we were not told. While actually they were told, but they had not internalized that message, and so when the 20% that not so good outcome happens, the first thing the patient today will do, the relatives will do, is blame the doctor. We did not get the right advice, you didn't do the right thing for us. Wish we had gone to somebody else and would have got a better outcome. How to handle this situation?
Very, very perfect. First of all, I should say you finished your concern in 90 seconds. Okay. I was counting the time simultaneously. And that's what happens. In just 90 seconds she spoke, and that was a concern. And that's what communication is all about. Do you have a solution to that after what I have spoken till now, before I give you the solution? Did you find a solution to what I have spoken? Did you manage something out of that?
Yes.
What's the solution?
I think the first thing that you told, that to break the things into different phases, tell the positive and separately the negative as well.
Take it later and send it to them. So these are the tricks to help you. And later on, that documentary evidence is going to help you even if something still goes amiss. But you have done it. The evidence is with you because you have posted it to them and the copy is in your records as well. Do you think that helps?
I think recording is probably the best solution. Sometimes when you are communicating with the patient, sometimes writing down a sentence and all looks very absurd and very non-communicative. You're just trying to write down and make you sign a particular thing. When you're trying to explain something, you're doing it in a friendly manner, trying to actually make that person understand. Most of the time when things go right and everything goes smooth, nothing happens. But if one thing that goes amiss, they just get back to you, forgetting everything that you explained, all the time you've taken, even the good things you've done. It doesn't take a minute for them to strike you back.
So my suggestion to you is chunking and checking. Even if you have been practicing it, try to practice it more. Reflect upon yourself, reflect upon your practice, and I will share with you more tricks how you can judge yourself better, how good you are by an independent observer, which I'll come to later. But the most important part, in the UK, in London, doctors with the consent of the patient record the whole conversation, and that recordings are kept safe for 10 to 20 years.